All right, let's dive into these DynaMed excerpts you sent over about hyponatremia. Looks like you're after the key takeaways for managing it safely and effectively, am I right?
You got it. And just to be clear, we're not talking about some simple electrolyte imbalance here. It's more like a high wire act, where both undercorrection and overcorrection can have some pretty serious consequences.
Oh, kidding. We're talking brain swelling, seizures, even death if you don't correct low sodium fast
Up
enough.
for it.
But overcorrected, and you risk triggering something called osmotic demyelination syndrome. And that, my friend, can cause permanent neurological damage. So yeah, we're going to break down how to walk that treatment tightrope safely and get those patients back on solid ground. What's really interesting here is how much hinges on how severe the hyponatremia actually is.
Absolutely. When we're dealing with severe hyponatremia, we're talking a sodium level below 125 MEQL. It's all about speed, but in a very controlled way.
Right, because in those severe cases, time is of the essence, literally. The guidelines, especially those from ECM-EAE and ERA-EDA, they all stress the importance of acting quickly.
Exactly. And that's where our trusty 3% hypertonic saline comes in. It creates this concentration gradient that pulls that excess water out of the brain way faster than regular saline could ever dream of.
Think of it like a controlled demolition. You've got to bring down the pressure in the brain carefully to avoid any more damage. So you start with 3% hypertonic saline. What's the typical game plan as those first crucial hours?
Well, the guidelines generally recommend taking it slow and steady. You typically start with 150 millil over 20 minutes, and you can repeat that up to 2 more times. Or until you see about a 5 MEQL increase in their sodium level. And this is but you're monitoring those sodium levels every 1 to 2 hours, especially at the beginning.
Because you're aiming for a controlled increase, not a complete turnaround right off the bat. And you can't just rely on lab values, right? You've got to keep a close eye on the patient's symptoms too.
Absolutely. You've got to look at the whole picture. Now, how much sodium correction is too much, especially in those first 24 hours? You really don't want to increase it by more than 8 to 10 MEQL, ideally.
And for those patients who are already at a higher risk of developing osmotic demyelination syndrome, we're talking about malnutrition, alcoholism, or folks who came in with severely low sodium to begin with, for them, you're aiming for an even stricter correction goal of 6 to 8 millieql. It's a delicate dance, isn't it?
It really is. It highlights just how critical it is to understand these guidelines inside and out. Meticulous monitoring is the name of the game when you're managing severe hyponatremia. But if you do it right, you can navigate those tricky waters and get those patients back to a healthy balance.
Okay, so we've covered the high wire act of severe hyponatremia, but not every case we see is an all-out emergency, right? Sometimes those sodium levels, they dip a little more gradually.
Yeah, you're right. It becomes less about making huge corrections quickly and more about being a detective and finding the root cause.
Because you can't just keep throwing sodium at the problem, can you? You've got to figure out why the body's holding on to all that extra water in the first place.
Exactly. So let's say you have a case of moderately severe hyponatremia, somewhere between 125 and 129 MEQL. These DynaMed excerpts you sent, they highlight a whole bunch of potential culprits, and this is where your clinical judgment really comes into play.
It's like a puzzle, isn't it? You've got their history, what medications they're on, their lab values, and you're trying to piece it all together and figure out what's driving that hyponatremia.
That's a great way to put it. And one of the first things you're thinking about is, are they showing any signs of fluid overload? Are they retaining water or are they losing fluids?
Because that makes a huge difference in how you treat them.
Right.
You mentioned GI fluid loss earlier. If someone's dealing with really bad vomiting or diarrhea, they're losing electrolytes like crazy, including sodium.
And that's the really important point here. In those cases, just pushing sodium without addressing that root cause is just like, it's like trying to inflate a tire that's got a hole in it.
You might see a little improvement, but it won't last.
Exactly. You got to find that hole first and plug it. Stop that fluid loss, and then you can carefully replenish what's been lost.
So you've got to be a bit of a plumber and a doctor at the same time.
That's a new one. But you're right, figuring out what's causing the fluid loss and tackling that is key. Now, let's say you've ruled out any obvious fluid loss, and your patient doesn't seem to be fluid overloaded. Another common culprit we see is SIADH.
SIADH, syndrome of inappropriate antidiuretic hormone secretion. That one always makes me think of some rogue hormone running around messing things up. Can you walk us through how that causes hyponatremia?
Think of your body like a swimming pool, right? You've got all these systems in place to maintain the perfect water balance. ADH, that antidiuretic hormone, it's like the pool cover. It helps conserve water when it's needed.
But in SIADH, It's like someone left the pool cover on all the time, even when it's overflowing.
Exactly. All that extra water, it dilutes the sodium in your blood, and there you have it, hyponatremia.
And this is where it gets tricky, right? The treatment for SIADH is fluid restriction, which seems totally backwards if you're thinking about low sodium.
It is a little counterintuitive. It can be tough to convince someone who's worried about low sodium that they actually need to drink less water. But remember, you're treating the underlying cause, not just the low sodium itself.
And sometimes treating the underlying cause means you've got to take a less obvious approach.
Speaking of less obvious approaches, let's talk about heart failure for a sec. You might think that a condition where the heart's not pumping well and there's fluid overload, that it would lead to high sodium. But often, it's the opposite.
It's true. The heart isn't pumping effectively, so the body freaks out a little and senses this as low blood volume. So what does it do? It tries to compensate by holding on to even more fluid, which just makes the heart's job even harder. And all that extra fluid, you guessed it, dilutes the sodium in the blood. It's a vicious cycle.
It really is. And managing hyponatremia on top of heart failure, well, let's just say it's not for the faint of heart.
Okay, now you're just trying to scare me. But seriously, how do you even approach managing hyponatremia when you've got this whole other cardiac situation going on?
Very carefully, that's for sure. The good news is that those DynaMed articles you sent, they lay out some clear guidelines. For mild to moderate cases, just restricting fluids aiming for less than 1.5 liters a day, that can be enough. And if you're seeing signs of fluid overload, that's when you might consider adding loop diuretics to the mix.
Loop diuretics, those are the big guns. I bet you have to monitor those patients super closely.
You're not wrong. It's a tightrope walk, that's for sure. You're trying to get rid of that excess fluid without sending those sodium levels into a free fall.
And don't forget about those medications we talked about earlier.
You're right, Vaptins might be an option in more severe cases. But again, you have to watch out for overcorrection like a hawk. And here's a key point. When you're dealing with heart failure, you also need to be super careful about potential drug interactions.
Because certain meds, like some diuretics and even some antidepressants, those can actually make the hyponatremia worse, right?
Exactly. It's like navigating a minefield sometimes. That's why it's so important to scrutinize that patient's medication list and consider all the factors that could be contributing.
So we've covered some of the usual suspects in the hyponatremia mystery: GI fluid loss, SIADH, heart failure. But I have a feeling our detective work isn't done yet. What other sneaky culprits are out there?
All right, we're back and ready to uncover some more of these sodium stealth thieves. We've covered a lot of ground already, but it sounds like our hyponatremia investigation is far from over. You're right, there are definitely a few more sneaky culprits out there, and some of them might surprise you.
Ooh, I do love a good surprise, especially when we're talking about medical mysteries. So what's up next on our list?
Well, up to this point, we've mainly focused on those conditions that affect how our bodies regulate water, but sometimes the culprit is way more direct. It's a problem with the kidneys themselves.
Makes sense. After all, the kidneys are basically the body's filtration system. They're essential for maintaining that delicate balance of fluids and electrolytes.
Exactly. And when those kidneys aren't working at their best, hyponatremia can be a big red flag that something's off.
Okay, so let's talk kidney culprits. What kind of renal shenanigans can throw those sodium levels out of whack?
Well, one scenario we see pretty frequently is nephrotic syndrome. Think of it like this. Your kidneys have these tiny little filters called glomeruli. In nephrotic syndrome, those filters, they get damaged and leaky.
Leaky filters, huh? So instead of doing their job and filtering out the waste products, they start letting important stuff slip through the cracks like protein.
Exactly. And when you lose protein like that, it throws off that osmotic balance, makes it harder for the body to hold on to fluid in the bloodstream. It's kind of like poking holes in a garden hose. Instead of the water staying inside and getting to your plants, it leaks out. Everything dries up.
So you end up with swelling because that fluid leaks into the tissues. And to make matters worse, you've got hyponatremia because the kidneys can't hang on to sodium like they should. That's adding insult to injury.
It is. It's a double whammy for sure. And to manage hyponatremia when you're dealing with nephrotic syndrome, well, you need a multi-pronged approach, get that swelling under control with diuretics, figure out what's causing it in the first place, and address that if you can, and of course, carefully manage those sodium levels.
It's like another one of those delicate balancing acts.
It is. And speaking of delicate balances, let's shift gears for a sec and talk about another potential kidney culprit: impaired kidney function.
Okay, so impaired kidney function. That one almost seems too obvious, doesn't it? If the kidneys aren't working right, it stands to reason that they'd have trouble keeping those sodium levels in check.
You'd think so, right? But here's the thing. Impaired kidney function, it's a really broad term. It covers a whole range of conditions, from something acute, like an injury, to something chronic, like kidney disease. And each of these conditions, they can mess with sodium balance in their own way.
So it's not a one-size-fits-all situation.
Exactly. You need to play detective, figure out what's causing those kidneys to struggle, and then tailor your treatment based on that.
Because, as we've said a few times already, treating the underlying cause, that's always the best approach when it comes to hyponatremia.
You got it. Now, while we're talking about kidneys and sodium, there's one more condition I want to touch on. It's called cerebral salt wasting, or CSW.
Cerebral salt wasting. Okay, that one's new. Sounds like something out of a medical thriller.
Right. It can definitely be a head scratcher, even for seasoned clinicians. So picture this. You've got a patient, they've had a brain injury, maybe a stroke, a head injury, maybe even brain surgery.
Okay, so we're talking some serious stuff here.
Yeah, we're talking serious. And as if the brain injury wasn't bad enough, now they start developing hyponatremia. But here's where it gets tricky. They're also showing signs of dehydration.
Wait a minute, dehydration. I thought hyponatremia meant there was too much water in the body, not too little.
That's the thing about CSW. It's like the body's wires get crossed. That brain injury, it can trigger the release of certain substances, and these substances make the kidneys dump sodium even though the body desperately needs it.
So the kidneys are basically working against the body's best interests here, sabotaging the sodium levels instead of maintaining them.
Exactly. And because where sodium goes, water follows, you end up with this double whammy of low sodium and dehydration. It's kind of like trying to fill up a bathtub while the drain's wide open. You're losing more than you're taking in.
Okay, that makes sense. Now, you mentioned that CSW is often misdiagnosed. What's it usually mistaken for, and why is it so crucial to get that diagnosis right?
CSW and SIADH, the one we talked about earlier. Yeah, they often get confused, especially after someone has a brain injury. Both can cause hyponatremia, but the way you treat them is completely different.
And giving the wrong treatment could have some pretty dire consequences.
You're right. If you restrict fluids for a patient with CSW because you think they've got SIADH, you're going to make that dehydration way worse. That's why it's so important to assess their volume status carefully. Are they fluid overloaded like they would be in SIADH, or are they showing signs of dehydration, dry mouth, things like that, which could point to CSW?
It's like navigating a minefield. One wrong step and...
Exactly. That's why we always have to stay on our toes, keep learning, and never be afraid to question what we think we know.
Well said. We've covered some pretty complex territory here. Leaky kidney filters, rogue hormones, even brain injuries that make the kidneys go haywire. What about those cases where hyponatremia isn't some medical mystery, but just a simple case of overdoing it?
You're talking about primary polydipsia. That's when someone drinks so much water that they dilute the sodium in their blood to a dangerous level.
That's the one. It's hard for me to imagine drinking that much water, but I guess it just goes to show that you really can have too much of a good thing.
For sure. Staying hydrated is essential, but it's all about balance. Listen to your body drink when you're thirsty, not just because you think you should.
Moderation is key in all things, right?
Yeah.
Including water. Now, before we get too caught up in all these hyponatremia culprits, we should probably touch on a couple of things that don't always get the attention they deserve.
You're right. Sometimes the most obvious culprits are the ones we tend to overlook.
Okay, so hit me with it. What often missed culprits are we forgetting about?
Well, one surprisingly common cause of hyponatremia is that people simply aren't getting enough sodium in their diet.
Wait, really? You can have low sodium because you're not eating enough salt?
Yeah.
That seems kind of counterintuitive, doesn't it?
I know, right? We're so used to hearing about all the problems that come with eating too much salt that we forget our bodies actually need some sodium to function properly.
True. And if you're not getting enough from your diet, your body will start dipping into its stores.
Exactly. And this can happen even if you're not intentionally restricting your salt intake. Sometimes it's just a matter of not eating enough food in general, which, let's face it, can be a problem for older adults or anyone dealing with certain health conditions.
So it's not just those marathon runners who are sweating out all their electrolytes. Even us regular folks can get into trouble if we're not paying attention to how much sodium we're taking in.
That's right. And speaking of marathon runners, we can't forget about exercise-associated hyponatremia, or EAH.
Right, that's when all that sweating and chugging water without replacing those lost electrolytes can really backfire.
Exactly. For most people who exercise regularly, EAH isn't a huge concern, but it's something to be mindful of, especially for those endurance athletes out there, or if you're exercising in really hot and humid conditions.
So the takeaway here is listen to your body, replace those electrolytes you're sweating out, and don't be afraid to reach for that sports drink when you need it.
Couldn't have said it better myself. Now, since we're on the topic of things that can make those sodium levels plummet, we've got to talk about a group of medications that often get overlooked as hyponatremia culprits, diuretics.
Diuretics, those are water pills, right? I get how they could lead to dehydration, but wouldn't that actually concentrate the sodium in the blood and make it go up, not down?
You'd think so, wouldn't you? But the problem is that diuretics, they're not picky. They flush out water, sure, but they also sweep away electrolytes in the process, and that includes sodium.
It's like collateral damage. You're trying to get rid of that extra fluid,
Yeah.
but you end up losing those precious electrolytes along the way.
Exactly. And that's why it's so important to keep a close eye on those electrolyte levels in anyone who's taking diuretics, especially if they're older or if they're on other medications that could also affect their sodium.
So it's all about being proactive, monitoring those electrolytes, and making adjustments as needed.
Absolutely. Now, before we wrap things up, there's one last piece of this puzzle I want to put in place. We've talked about all the different ways hyponatremia can develop, but what happens when the body's own hormone production goes off the rails?
Ooh, okay. Tell me more about these hormonal twists and turns.
So remember how important hormones are for regulating that sodium and water balance? When those hormones are out of whack, hyponatremia can be a telltale sign that something's not right.
Makes sense. So which hormonal imbalances are we talking about here?
Well, one that we see pop up sometimes is mineralocorticoid deficiency. Remember aldosterone, that hormone that helps the kidneys hold on to sodium? When those aldosterone levels are low, the kidneys start dumping sodium like it's going out of style.
So it's like the sodium bodyguard just took off. And like we said before, when sodium goes, water follows, and that leads to
Hyponatremia and dehydration, a recipe for disaster. And while we're on the topic of hormone deficiencies, we can't forget about corticosteroid deficiency.
corticosteroid deficiency. Now that one rings a bell. That's got something to do with the adrenal glands, right?
That's right. Corticosteroids are hormones. They're produced by the adrenal glands, and they play a role in a ton of bodily functions, including, you guessed it, regulating that sodium balance.
So when corticosteroid levels are low, all that careful sodium regulation can go right out the window.
You got it. And just like with a mineralocorticoid deficiency, treating a corticosteroid deficiency often means replacing those missing hormones with medication.
Okay, so we've navigated our way through a maze of hyponatremia culprits today, from obvious fluid loss to those sneaky hormonal imbalances. Seems like every system in the body has a part to play.
It really highlights how interconnected the human body is, doesn't it? It's pretty amazing.
It really is. So as we wrap up this deep dive, what's the most important thing you want our listeners to take away from all of this?
That's a great question. I think the biggest takeaway here is that managing hyponatremia is rarely as simple as just giving someone sodium. It's about understanding what's going on beneath the surface, why those levels are low in the first place, carefully assessing what each individual patient needs, and remembering that even when we're dealing with something as seemingly straightforward as sodium and water, the human body has a way of throwing us a curveball every now and then.
Couldn't agree more. And on that note, we'll wrap up this deep dive into hyponatremia. Thanks for joining us. Until next time, keep those brains engaged and remember, knowledge is power.